it's great to see so many people here today, and I think you will be very pleased to hear Dr. Perillo speak to us about the common factors that can bias clinical judgment in psycholegal contexts. And if you haven't yet met Dr. Perillo, he's an excellent addition to our department. He's an associate professor in psychiatry and behavioral sciences and the training director for our forensic psychology postdoctoral program. So Dr. Perillo is a licensed psychologist who has conducted numerous forensic evaluations locally for the county and at federal levels, and also received the American Psychology Law Society's early career teaching and mentoring work for his work with forensic trainees. So we are very proud of Dr. Perillo, and he recently completed a project with Dr. Jen Perillo examining cognitive and legal factors that lead to biased forensic evaluations. And we are welcoming him today to speak about, as I mentioned, some of those common factors. So take it away, Dr. Perillo.
All right. Thank you so much, Deb. No pressure there, but what a lovely intro. I appreciate it. So as was just explained, I am a forensic psychologist at heart, and a lot of the work that I have done goes under the perspective of trying to leave forensic psychology in the field a little bit better than I found it. I've focused a lot of my work on reducing bias in forensic assessment. Some of that through work with my colleague and collaborator, Dr. Jen Perillo, who's also on the call. And a lot of the work that we've done as we've seen the issue of bias in forensic assessment, we've seen that a lot of the processes that explain why it happens can actually generalize and be useful in other clinical assessments as well. So the talk here is focused primarily on legal evaluations. That's what I know, that's what I focus on, but I've tried to generalize some of the examples, and I encourage you to consider how some of the principles I go over in this might apply to the work that you do. Now, overall, the learning objectives here, I want us to talk about aspects of a forensic evaluation that are inherent to the nature of doing one that can increase the risk that our ultimate judgments and opinions end up being a little bit skewed in a biased way. I'm also then going to explain some of the cognitive factors that potentially bias our judgment during these forensic evaluations, and we'll look at how that might not have to be just because it's a forensic evaluation, how that can generalize to other evaluations as well. And then after understanding the why, perhaps then we can discuss strategies that can address evaluation bias, including some of the logistic challenges that might be there in terms of implementing these. So in forensic psychology, our guidelines tell us that we have a mission, we strive to be unbiased and impartial in our evaluations. Now, we are all generally in what we might refer to as a helping field, but when we do specific forensic evaluations, the help we provide is often a little bit different. Instead of providing information for a client and potentially collaborating on treatment goals or providing conclusions in the context of goals that your client has in front of you, sometimes the person you interview isn't even your client or your patient. Sometimes you're being hired by a court and the court is your client. Sometimes you're being hired by an attorney and the attorney is your client there. In this situation, the help that we're giving is often information to help other people make legal judgments. And so we try to be impartial and provide helpful information there. But there's this tension between our usual advocacy and service kind of field and providing this unbiased, impartial information. Overall, their impartiality, I would argue, is impossible. We are all humans in clinical evaluations. Humans have bias and error, and that leaks into our evaluations. The goal is not to eliminate bias. That's the ideal, but a realistic goal is more about reducing bias and becoming aware of where those biases might be so that we can increase the odds that we reduce the impact it has on our evaluations. So, our understanding of bias in forensic evaluations has been around for over 50 years now, primarily from field work. There was an investigation of the Buffalo Creek disaster of 1972, where there was a massive flood in West Virginia that was determined to be caused by the collapse of a coal slag heap. And over 2,000 people sued the coal company for psychological damages related to the massive flood that had led to several deaths in the community. And these people were evaluated by psychiatrists. And what we found was that these people, when they were evaluated, psychiatrists that were hired by the plaintiffs themselves tended to find more psychological injury than those psychiatrists that had been hired by the defense. So they're talking to the same people, but finding in ways that ended up helping the defense or helping the plaintiffs. And there was a case examination of 42 people that were evaluated by both sides. So they were evaluated multiple times around the same time frame. So the exact same client, but the difference was you were being hired by the plaintiff or you were being hired by the defense. And we saw the same trend here, where psychiatrists disagreed on the psychological injury for the exact same people, and it was predicted by what side hired you. Now, one of our instincts here might be, well, they're coming to some sort of agreement on mental health symptoms, but because of the idea of liability, where they're disagreeing is on liability. Well, although that is true, what the investigation found was those psychiatrists that were hired by the defense not only were less likely to find psychological damages, but they were less likely to find any psychological or psychiatric impairment, period, in the exact same person. So it wasn't just their conclusions, but also their general impressions of the person. In the 1980s, this was coined forensic identification, this idea that being hired by a side, you unintentionally start to fit your approach to the evaluation to help follow the narrative of who hired you. And we've seen in a lot of field studies in decades after that, where evaluators would look at the same person, they disagree, but a predictor of where they disagreed was who hired them. And that defense hired experts tended to have judgments that favored a defense side, and prosecution hired experts had conclusions that favored the prosecution. There were a lot of arguments about whether or not this was about the evaluation, because some people said, well, that's bias about the evaluators themselves. That's bias from, that's a strategic thing from attorneys. And so this is a unique thing about those evaluators are biased. So defense hired experts are people that want to work for the defense. And so they're already coming in with some inherent biases, and people that are willing to work for the prosecution are coming in with their own kind of ideological biases that bias them. Well, in 2013, there was an experiment that had forensic evaluators receive the same training on psychopathy assessments and sexual risk assessment. And as a condition of doing this free training, they were told after this they would give their services for free forensic consults by scoring instruments on psychopathy and sexual risk. What they didn't know is they were part of an experiment. And half of the people were randomly told that the cases that they were going to look at were from a defense firm that tries to show that not all offenders have high risks for reoffending. And half of the people were told they were being hired by a state prosecution agency that tries to highlight the people that are at the highest risk of offending. So they didn't tell people to find one way or another. And everybody looked at the exact same data. The only difference was that early little framing of who wanted to hire you. And what we saw in this experiment was that when people were told that the cases were coming from the defense, they tended to interpret the exact same information in ways that lowered risk score and lowered levels of psychopathy. In other words, that would help the defense if somebody had a lower risk for reoffending and were determined to have a lower risk of, or a lower demonstration of psychopathy. And the prosecution framed experts scored higher. scored the same person as a higher risk for reoffending and at higher levels of psychopathy. So we started to see more and more, and in related experiments after this, that bias in forensic evaluations isn't just any kind of inherent bias that we have as people or our ideological biases that we bring to the table, but there's something about being hired by a side and something about the legal process itself that also nudges people a certain way. This concept these days is called adversarial allegiance, which in the court adversarial system is the idea of our tendency to unintentionally judge in favor of the side that requested our services. So the emphasis here is on the unintentionality part of this, that the bias is not deliberate. It's not by someone seeking to help the defense, seeking to help the prosecution. It's someone that's striving to be impartial, just like the guidelines suggest. And we've seen this very consistently in a number of different types of evaluations. And so the idea here was that there is something inherent about legal evaluations. We're getting a referral source. We're trying to help our referral, perhaps unconsciously. We get contextual info. And as we'll discuss in these next sections here, our increased understanding of this is it's not just about the side that hires you and your judgment that's biased, but perhaps your process of your evaluation that then helps you find in the side that retained for you. So in trying to understand these factors that contribute to bias, I'd like to present a scenario here for you. And this is partially based on a scenario that came across last year with one of my forensic postdocs. So I want you to imagine that you were asked to do a diagnostic evaluation for somebody. And all you know is that it's a second opinion. So this person has been evaluated before, and they're asking for a second opinion on what's going on. And you have access to that initial report. The next slide, as a heads up, Robin, is where the poll would be. And so I'm gonna have a poll. I just want your thoughts here. The question is, if you had access to that initial report, when would you want to look at it? Would you want to look at it immediately before you actually do your evaluation? Would you want to do it? Would you want to review that report sometimes in the middle? So after you actually meet the person and do the interview, but then before you've actually made a diagnosis or set your opinion? Or is it like one of the last things that you want to look at, that you're gonna do your interview, look at any other things you do, and then you'll look at the other report before you form an opinion? So if we could put up that poll and see what people think. There is no right or wrong answer here, perhaps, but just want to get a sense of what people would do in this situation and why. Okay, you'll keep that open for a bit while we're tallying the results here. I'm going to add the unique flavor to this that came up during the postdoc last year. So in the situation that we had, this was my postdoctoral resident who was doing the evaluation. It was actually a competency evaluation. She knew that it was a second opinion competency evaluation, and she saw who had done the evaluation because of the contextual information, and it was by a very well-known forensic evaluator. And what she told me in supervision was, I don't know if I want to look at this because I don't think I can disagree with him. I'm a lowly postdoctoral fellow, and this person is well known in the field. I don't know how I can say this person is wrong. So what she was saying in this conversation was that by looking at the other evaluator's impressions, it might skew or shape her in a way that could bias how she approaches the evaluation or what her impressions would be. So I guess we could go ahead and close the poll and see if there are any results from that. Okay, so we've got a little bit, the majority of people saying they would look at that as one of the last things. When I did this for forensic evaluators specifically, there was much more of a split of people saying that's one of the first thing they would look at before they do their interview. And so some of this might be the contextual information, but I want you to think about, the process of your evaluation can shape your findings, as we'll see with some of the discussion here. And so it's really important to always consider what you're looking at, but also think about what information you would want from that report, because I'm going to come up to this scenario another couple of times during this discussion here. Now, one issue that doesn't necessarily explain why we are biased as much as it does why we remain biased, what maintains bias in our evaluations, is our ignorance of bias itself. So as people, we tend to be better at recognizing bias in other people than in ourselves. Why? Well, we often use introspection. We're introspecting to screen our own bias, but this bias that we're talking about is often unconscious. We're not aware of why we're biased toward the person in front of us, and so we can't see what we can't see. We're better at identifying biases in other people than in our own. And because of that, we oftentimes perceive that if somebody disagrees with us, it's them that are biased rather than us. We have this sense of naive realism that what we observe in the world is what is true and reflective of reality. And that if somebody else disagrees with us, they saw things wrong in a biased kind of way. We see this trend in evaluations, and we see this trend when we look at in-groups and out-groups. So for example, when we look at in forensic evaluations, forensic psychiatrists tend to think that forensic psychologists are more biased, and forensic psychologists think that forensic psychiatrists are more biased. You also see that early career professionals tend to think that more senior clinicians, perhaps arguing that they don't keep up with the literature as much and they're getting set of their ways. They think that senior clinicians are more biased than early career people. And senior clinicians say that early career people don't have as much experience, don't have as much training, and therefore are more biased than senior clinicians. So this does come up a lot, and we're better at identifying the bias in other people than in ourselves. If we don't know that we're biased, or we go into an evaluation assuming that we're impartial, we can't address what we don't see. So if we're not looking for our own biases of why we might be wrong in an evaluation or why we might have interpreted things differently, it's hard for us to address those biases that exist as a part of our human nature. Even for things that we might consider objective psychological data, we use that data in subjective ways. We choose when to administer those instruments. We choose how to present those in our reports. We choose how much weight to give them in our impressions. So even with little information like that, we can use what we would call objective information in subjective and unbiased ways. And by denying that fact, it increases the likelihood or decreases the likelihood that you can address those biases when they do come in your evaluations. So why might this happen? Well, in forensic contexts, there's this natural tension between our goals as clinical workers and the legal system. In an adversarial system, the sides are supposed to be biased. The defense, at the very least, is specifically tasked with advocating for the defendant's side. They are not supposed to come in as a neutral party. So if a defense expert hires you, they are trying to produce a narrative that helps their side as much as possible. In the court system, it is less about the truth in that aspect of a trial or hearing. And you coming in as a clinician that is trying to be impartial and biased, there's this natural tension of being hired by a side and your duty to remain impartial. By accepting a referral, there's this internal cognitive commitment where you have agreed to provide a service for someone. And even though you're saying, well, my evaluation may not help you, there's still this tension between wanting to help the people that have asked for your services. And so there can be some motivation to reduce that tension between my ability to be my duty to be impartial and working for a side. Now, there's also different ways that we can reduce that tension, but wouldn't it be nice and convenient if the facts of the case actually help the side, where I am impartial and I get to help that side because they're right? We are motivated to look at a case that way in a forensic evaluation. We don't go into it consciously thinking that way, but a simple way to reduce this tension between our desire to be fair and impartial and working for a side is that we believe we do an impartial evaluation and it helps the side that hired us. If being with a trainee, my trainee said her tension was she would have bias in doing an evaluation that would agree with that well-known psychologist. In psychiatry broadly, thinking about in supervisory relationships, there might be a deference to your supervisor if they frame the case a certain way. If they know the person that you're about to see and evaluate and give you some context, you might be motivated to agree with your supervisor. And so there's this disconnect between, like, if you see any information where your supervisor might be wrong, subtly, unconsciously, you might give the benefit of the doubt to some of the other information that helps you find the way that you can agree with your supervisor. Now, another concept, and this one particularly starts to generalize to broader evaluations, that we start to see can explain potentially forensic bias, is the concept of anchoring. And anchoring is the idea that the early info we get in an evaluation shapes what we expect to see in the future and therefore shapes our judgment. That we are no longer, once we get early information, we're no longer truly calibrated to be right in the middle, and we've kind of been nudged one side ever so subtly. So how this comes up in forensic evaluations is, if you are hired by the defense or you're hired by the prosecution, they're going to give you some context of why they're asking you to do this evaluation. And that framing of how they initially present the case nudges you ever so slightly to find in that way. If anybody here has ever tried to resolve a fight between two siblings or two friends, and you only got one side first, and you go in talking to the other friend or sibling kind of upset at them already, that's anchoring at its core, where you actually haven't heard the other side yet, but it's been framed in a way that has you expecting to be upset at the other side because the person is coming in biased. Now, thinking about how you do an evaluation with a child. If any of you have done an evaluation with a child, think about situations where you have talked to the parent first versus times that you've talked to the child first, versus maybe times that you've talked to a school first. And thinking about how that early information shapes the questions you ask those other people. You might approach an interview with a child a little bit differently if they're the first person you've seen versus if you've talked to the parent extensively and they've given you their opinions, their impressions, and all that. And the reverse is also true as well. You talk to a child first, and then you're going to talk to the parent. How you approach that parent conversation, the questions you ask, even the way that you ask them, can be shaped by how your experience was with the child. You're not coming into the parent evaluation anymore with a completely blank slate. So this is again where my postdoc's concern was that the initial, if she looked at that second opinion evaluation first, that it could skew her. Related to this concept of anchoring is the idea of confirmation bias, where as people, we tend to be way better at looking for information that supports what we think than looking for information that will prove us wrong. We don't like to think of ourselves as being wrong. So we spend more mental resources in the world looking for things that prove that we're right, better than more than resources that prove that we're wrong. And you can think about this just for any kind of information where you're looking to see if something is true or not. You tend to ask like, is that true? Let me see if that's true, rather than, is that true? Let me try to prove if that's false. It's just how we tend to look at things. We tend to look for information that supports our side. So by anchoring in one certain way, it's possible that we naturally then look for information that is going to support the side that we've subtly been nudged toward. So in this concept of confirmation bias, we tend to, if we find information that actually contradicts what we early on believed, we have a natural tendency and a natural motivation to either downplay the significance of that information or just flat out ignore it. If you've ever had past psychiatric records and it had a diagnosis that didn't match what you saw, and you notice in retrospect, you kind of looked at it and go, that didn't match. Oh, well. And you just kind of moved on and didn't give it a lot of serious contemplation of why that might not match. That's an example of confirmation bias in action, where we have a natural tendency and a motivation to just more quickly move on if it doesn't support what we're already thinking. We tend to then overestimate how strong the evidence is if something does support us. So if we see psych records that match the diagnosis we thought, we're going, hey, that's really strong evidence, again, that supports our diagnosis. Even if we looked at the records and the process from forming that diagnosis is a little bit shaky, we tend to overestimate how strong that evidence actually is. And then if the evidence is more ambiguous, we tend to give the benefit of the doubt to any information that's more supportive for us. All of this produces our increased likelihood that as we start to shape our judgments, we are more and more going down a path that helps us find what we're looking for or what we're motivated to see. Now, one experimental study that is still under peer review. This is a study that Dr. Jen Perillo and my former dissertation student did that looked at diagnosis and confirmation bias in a really unique forensic evaluation, which is the indefinite commitment of what we call sexually violent predators. People that have been convicted of a sex offense, whether this person had a mental abnormality that increases their risk for reoffending, and therefore they should be indefinitely committed. And we had evaluators review simulated intake information and form impressions on SVP commitment of whether or not this person had a diagnosable mental health condition that increased the risk for sexually reoffending in the future. And the red circle I have here is one of our conditions here, where half of the people got included this diagnosis of pedophilic disorder on the intake report. We didn't say what that was based on. We didn't put any information about pedophilic disorder in that diagnosis there. All we said was they have that diagnosis. And half of the people didn't get that label at the beginning of their evaluation. But then even more so, in the rest of the intake, half the people got information that directly contradicted any indication of pedophilic disorder. All sexual fantasies being for adults, for example, nothing indicating genuine attraction to children. So one of our curiosities here is what happens when we put that diagnosis there, but all the information after it doesn't point to pedophilic disorder? What's going to happen? Well, this paper is under peer review right now, but what we saw was that both the information in the report and that diagnosis predicted clinicians' impressions. If we put that diagnosis there, people were far more likely to diagnose pedophilic disorder, even when the information after it directly contradicted a diagnosis of pedophilic disorder. And then even more concerning in this is that when people diagnosed pedophilic disorder, it increased their risk to diagnose or recommend indefinite civil commitment, regardless of what the information was in the rest of the evaluation. So our take home from this is an idea that early information can then help us unintentionally interpret the rest of information in ways that fits a particular narrative. So how do we actually address these different biases that can come in an evaluation? It's easier said than done. It can be very complicated. And I call these strategies rather than solutions for a reason. Again, this idea that we can eliminate bias, I don't think is realistic. But strategies to reduce it, we can certainly go forth with those. So one proposed idea is this concept of engaging in counterfactual reasoning. And I've chosen to focus primarily on those recommendations in forensic practice that would more likely generalize to non-forensic evaluations, this being one of them. Well, if we have a tendency to engage in confirmation bias, a tendency to look for reasons that we're right, what if we more actively during our evaluation reframed our question and thought about looking for information that would prove us wrong? So essentially, as you're writing your report that has diagnostic impressions, thinking about why would someone disagree with me? Why might I be wrong? and then keeping the door open that you could be wrong and looking for ways to explore the possibility of that. And only by eliminating all of the other possibilities do you come at an increased confidence in your findings. So the idea here would be to extend what we often do in supervision. For anybody that's a supervisor, you might have had a resident or a fellow who's talking about a case, and you might challenge them on, well, what's another reason that they might have presented like that? Or could it be this? Could it be this diagnosis instead of this? Basically, we should all be our own supervisors in this context. And it's this encouragement of us, rather than looking at, these are the reasons I'm right, is to continue to ask yourself, what else might it be? Why might another clinician disagree with me? And looking at whether or not that is still a realistic possibility in the situation. So we have seen, by asking people to engage in this counterfactual reasoning. So you have an impression and you try to reason the counter to it, why you might be wrong. We see that this has reduced overconfidence in some forensic areas, and even broadly in neuropsych diagnosis, particularly for highly suggestive diagnoses, that we see lower rates of confidence in certain neuropsychological diagnoses when we have people consider alternate explanations for certain cognitive deficits or presentations that they see. But there are a lot of questions about counterfactual reasoning that can be complicated in order for us to implement this in practice. So one is, what are we actually countering? So are we just countering our conclusions, or are we countering all of our data points? Because what we see is that counterfactual reasoning is much more effective when it's done early, rather than when it's done late. So the idea here is that if you just do your evaluation, you come up with an impression, and then you ask yourself, oh, why might I be wrong? You've probably tipped the scales too much right at that point for it to be as effective. But if you look at your early impressions and look at why those might be wrong before you gather more information, now it's going to not only have more impact, but it also might affect the rest of your evaluation. Oh, I might seek collateral contact information from this person to see if this is right or wrong. Oh, I might request some additional hospital records that I might not otherwise have thought about looking at because I have an alternate diagnosis I might be coming up. So the idea here is that for counterfactual reasoning to be effective, it should be done early, and it should be done periodically through the evaluation. That's a lot of mental effort. That's a lot of task on us. And it's also, we are the ones that are accountable to ourselves to do this. So it's hard to implement in practice if we are not making a commitment to do it. So again, as I noted here, the evidence suggests that this is more effective if we do it early, before we make our impressions, rather than after. The earlier you counter yourself, the greater impact it can have on the rest of your evaluation, because it increases the odds that the earlier you do it, you're going to get at that early counter and that early anchoring and framing information. Now, another idea would be to approach clinical evaluations very scientifically and to limit your clinical review to only information that is relevant to the referral question. So I'm going to take a step back and look at how this has been relevant in other forensic science experiments that we've seen, where we've seen forensic studies with handwriting experts, where there's a suspect and the state might come to a forensic handwriting expert and say, hey, we've got a signature here. Does it match? Does this signature on this incriminating information match the defendant? And sometimes those people get information that, oh, the person's already confessed. Now, in theory, right, that confession is completely irrelevant to a person looking at handwriting and seeing whether it matches or not. That should have no bearing on their impression of matches, right? But it does. We see that if you provide that information that theoretically and realistically is irrelevant to the handwriting information, a confession is not relevant to whether these two samples match. But we see if you provide that framing about that this person confessed, forensic handwriting experts were much more likely to find a match between the two handwriting samples than if they weren't given that information. Now we see this in forensic evaluations too, and the idea here would be that by limiting your searches to only information that will inform your evaluation, it increases the odds that you will be less biased by other kinds of noise. So one thing, if we take a step back and think about my forensic postdoc, where she wanted to review the report, but she wanted to review it later. One question I had was, well, what do you want to know from the report? What is actually relevant to your evaluation? And there were a couple of things that through that discussion, we actually highlighted. There's some stuff that she wants to know later, but there's some stuff from that report that she actually wants to know now that perhaps she should review this early. So for example, this is a second opinion evaluation, and she wanted to know what testing had been done. Because what if she does a test that this person just completed 2 months ago that has practice effects, where this person, by the fact that they did this test 2 months ago, now they do this test with her, and it might overestimate this person's actual memory or cognitive abilities if they've been able to practice. So she wanted to know what's been done so she knows not to do that in her evaluation. But she didn't want to know the evaluator's opinions because she was afraid that that would skew her. I'll get into how we resolved that a little bit later on. Now, one complication here is that task-relevant information is not universal. So I'd like you to think about information that could be helpful answering one psychiatric evaluation question, but that wouldn't help you with another one. Even if broadly you're asked to do a psychiatric eval, there are certain questions that you're asked or certain patients that come in where certain information will be helpful for one case, but it might not be helpful for the other. But I want to go even further with that. Are there any situations or information that you could think of that would be helpful answering one evaluation question and not only would be unhelpful, but might actually be biasing, might harm your evaluation, might help skew you to be wrong than another? I'm going to bring up a potentially loaded example of, particularly in forensic work and how we've seen it implemented in some studies of forensic pathology, victim race. So most of the time, I think we would say for a lot of forensic evaluations, victim race shouldn't be relevant to, say, somebody's criminal responsibility. If we do what we call an insanity evaluation, victim race shouldn't be relevant in most cases where we're determining whether someone had a mental health condition that made them unaware of what they were doing at the time, or unaware that what they were doing was wrong. But if during this insanity evaluation, it comes up that this person has an extensive psychotic history that are related to delusions about their race being persecuted by people of another race, and they have these diatribes about they and other people of their race have been threatened, now all of a sudden, if this is a case of a victim of them assaulting somebody of a different race that is consistent with their delusions about, I need to protect myself because there's this vast conspiracy about people of a certain race attacking mine for purely psychotic reasons, in that particular case, race of the victim might be relevant to this narrative of, was this consistent with this person's psychotic delusions at the time? That might explain why they engaged in violent behavior at the time. But if we think of a lot of other cases where this would be biasing, we see in forensics pathology cases, particular controversy of what a lot of us hear as shaken baby syndrome, where the other Dr. Perillo and my colleague, Jeff Kakuka and ETL Dror, did some studies on looking at forensic pathologists, board-certified forensic pathologists' expert opinions on looking at post-mortem examinations of a child that died with skull fractures and hematomas and all that, and looked at whether or not they thought the child died of an accident or whether they attributed the death to a homicide, shaken baby syndrome, consistent with shaken baby syndrome. And what they found was when they added extraneous, irrelevant information with all the medical data they had, including the victim's race, that they identified and the caretaker's race, they identified homicide or determined the case was a homicide more when the baby and the caretaker were Black than when the caretaker and the baby were white. So we see that that shouldn't have been relevant, and in fact led to biased interpretations of information, increasing the likelihood of identifying the exact same medical data as being caused by a homicide than being caused by natural causes or an accident. So the idea here would be get rid of the noise, filter out information that's not actually going to help you answer the question you've been asked to answer, and only look at the things that would help you. But the problem is, what is relevant? Sometimes you won't know what's relevant until you look at it. And once you look at it, you can't unring the bell. So in my postdoc situation there, if she looked at the report looking for testing data and she looks at some other stuff, she might think that, oh, maybe I can erase this out of my head. We're not good at doing that. Once you look at biasing information, it's there, and it increases the odds that it can shape your opinions there on out. So this is an area of future research, because there's a lot of different evaluations with different questions about what's relevant for one evaluation versus what's relevant for another. Now, another technique that sort of combines this task relevance with some elements of counterfactual reasoning is this concept of linear sequential unmasking, or at least it lets us look at things that kind of combines these things that I've talked about here. And I'm going to talk briefly about a process called linear sequential unmasking expanded. This sounds really fancy, but if you just break down what the words there are saying there, we're talking about linearly in a particular order, a particular sequence, unmasking data points. So in other words, the idea here is that you are in a specific order, one by one, looking at different clinical data as you form your opinion, reviewing that data in isolation, and then judging that information in isolation, and then incrementally overall. So one example would be if you looked at the records first, stopping and judging and evaluating the records for what it says. Individually, how much does these records lean this way versus this way? Then if you interviewed the client, then saying, all right, just from the data I got from the interview, how much does this lean this way or this way? Then with all the information, how much does it lean this way or this way? The idea here is that you are practicing and forcing yourself to evaluate each individual piece of information for its worth, rather than being unintentionally giving undue weight to certain pieces of information. Because if you start to commit earlier on that certain records might not really be that strong one way or another, it protects you from overinflating the strength of that later on. If you've gone ahead and declared at the beginning, these records weren't really that helpful, it makes it harder for you at the end to emphasize this is consistent with prior records. So the idea is that it helps you decrease that bias. There are a lot of complications around sequence considerations in terms of well, what's the order in the evaluation? Dr. Jen Perillo and I, again, we did a recent study that I referenced here. Can't really talk about it now for sake of time, but some of us, we have questioned how much of the order might actually matter, or how precise the order really needs to be. But one idea here is that if there is stuff that is potentially biasing, it should be some of the last things you look at. The most subjective data points should be some of the first things that you look at, and the most relevant stuff should be the first things that you look at. So in the scenario of the first evaluation, it could be high biasing. Depending on the kind of evaluation, we can agree or disagree on how objective it is, but it could be pretty relevant to our evaluation. Victim race, in my other example there, is in almost all cases going to be biasing and not relevant for most. So even if we uncovered what the victim's race is in these situations, it would generally be recommended to be one of the last bells that we ring, if we unring that bell at all. Now, why might this work? Well, again, we're filtering out irrelevant information if we've set the rules ahead of time of, I'm going to look at this, and then this, and then this. It limits our range of confirmation bias by making sure that we're challenging each piece of information as we go forth. And it helps us promote counterfactual reasoning by not overwhelming ourselves with a bunch of data and filtering out the information that doesn't support our side. The evidence around linear sequential unmasking is fairly in its early stages. Right now, it's more theoretical in forensic science. The studies so far have been more about helping get rid of the noise than this technique actually reducing bias. And we haven't seen it much in actual practice, but the theoretical implications of it are fairly strong. Now, of course, again, some challenges. What is the order? We can't always know what won't be relevant. And it's going to also depend practically. Sometimes we want to do things in a certain order. Like if I want to review records first, well, has anybody here tried to get records from another hospital? Does it always come at a snap like that? No. Sometimes I might want to review something that's just not there. Or I want to call somebody's parents, and now I've got to get them on the phone. Good luck with that in certain points. Sometimes the order is just the order that we're actually able to do it in, rather than in an ideal world. I'm going to skip over discussions of masked referral, which is an area that Dr. Jen Perillo and I have emphasized in some recent work here, which is basically this idea that masking who actually hires you and having all the communication channeled through a third party. But the idea here is that it would reduce adversarial allegiance. Perhaps in some ways, but again, we've seen a lot of this as unintentional, and that early information can still be filtered in. So we're a little bit more skeptical of that being a remedy for all of this. But going back to my forensic postdoc, another masking idea is, what if you channeled information through a third party, which is what my postdoc and I did. So I looked at the evaluator's report rather than her. Why did I do this? Well, she wanted to know the testing results or testing that had been done, but she didn't want to know the forensic evaluator's opinions. Well, I can do that for her. I can look at the report, since I'm not doing the evaluation, and tell her what testing has been done and when, so that she has that information without being shaped by all the other stuff from the other evaluator. Now, for other bits of information, this could be hard because, well, it might remove my my postdoc's bias, but now my bias comes to the table. What do I decide is important to tell my postdoc? How do I frame this information to my postdoc? So masking in these kinds of ways, if we had a supervisor that can share information from us so we reduce noise, well, we're bringing another potentially biased person into the party, so to speak. So it could be helpful in some ways, but now the onus is on me as the supervisor in order to reduce bias and give her the information that's relevant. So some final thoughts about all of this and how it generalizes to evaluation bias in practice. What I want you to take home from all of this is that when we talk about biased evaluations, it's not just about our conclusions, it's actually about our process. That early information can shape how we go through an evaluation and how we interpret evidence in an evaluation. It can bias the very info we seek in the first place. That because bias can come early in evaluation, whatever we do to address it should be done early. Early intervention is our key to reduce evaluation bias, rather than something separate we do at the end. None of these strategies are perfect, but as we know in public health work, we can use things together to systematically maximize effectiveness. So these strategies that I've talked about here, I'm not advocating for one or another, but in certain contexts, they might be more or less relevant and used together to maximize our ability to reduce bias. And when we're in supervisory contexts, is there a way for us to help each other out by filtering info for colleagues that could be potentially irrelevant and unbiasing, or irrelevant and biasing, so that our residents, our fellows, can have access to some information while reducing the likelihood that the noise can unintentionally bias their opinions? That's something that is an empirical question. We could look up at this hospital or otherwise. But I will leave it at that and open it for any questions that you might have.
Thank you, Dr. Perillo. That was a great presentation. I listened keenly. I hope my microphone is working. I was curious. I wanted to ask you, do you see any particular biases among evaluators earlier on in their career? I think you mentioned it briefly, but I didn't quite catch it. But to be on the lookout sort of when you're new to this field and you're training in this field versus evaluators of more seniority and experience.
There's a lot of noise and some different aspects that can explain why certain bias might perpetuate in early career professionals versus more senior professionals. My recollection of some of that work is that I mean, one, everybody is prone to the bias, but I don't see that people are particularly more biased in early career compared to more senior. We don't see a relationship in experience levels and your susceptibility to it. And we, just as importantly, we don't see a correlation between your early experience or your level of experience and actual bias in your conclusions. This is in general and specifically in the studies that Jen Perillo and I have done, where we've asked people for their levels of experience when we're testing their biases, and we've looked at those correlations and don't really find anything.
And that pertains also to the specific types of biases, though.
There's nothing to suggest that it would. That early career professionals would be prone to a particular bias in that context. Now, I give the example of the second opinion evaluation, but the counter in second opinion evaluations is just as vulnerable to that. So, in other words, the other framing of a second opinion case is if you're asked to do a second opinion on a diagnostic evaluation. In certain contexts, the implications are there. You're looking for the idea that the other person did a bad job or the other person is wrong. Why are we asking for a second opinion here? And if the context comes up there, well, now we're looking instead of like why we're going to be right with the other evaluator, we're coming in expecting to disagree with them in some form. And so that is something that we're just as vulnerable at early career versus late career.
So an example for that, if you would be exposed to a similar request, you would acknowledge those settings that, well, it might be an expert and it might be a reason for the referral in the first place, and you sort of go in keeping that in mind.
Go in keeping that in mind and continuing to challenge yourself of why might that, if you're seeing it differently than the other evaluator after a point, why might they be seeing it differently than I am? And some of it might be my diagnostic impressions. Some might be difference in what I'm observing in the room. Some might be differences in testing data. But the idea is always zooming out and thinking about why I might be wrong so that you're challenging yourself to continue to look at the big picture of all the information you have. And it's only by continuing to look at everything that we're not zooming in and missing something important.
Yeah, no, thank you very much. I appreciate
certainly.
that.
Thank you, Dr. Perillo, for your talk. It was very enlightening. I'm not by any means an expert in this public health student currently and work in the department, but it was very interesting, your talk, and just thinking about the concept of blinding while you're doing this work. Just really interesting. I'm glad I came to the Grand Rounds today because I learned a lot of things I didn't know otherwise. So thank you.
Absolutely. Thanks a lot. Yeah. When you talked about that, when we're unmasking about masking ourselves from the referral source, this reminds me of a practical issue I've seen just in my year here doing court-ordered evaluations. Some people think that court-ordered evaluations is the solution to forensic bias so that you're not hired by either side. it's not for a number of different reasons. But what I've noticed anecdotally that can highlight that in the context of competency evaluations in Bernalillo County in particular, that even though technically I'm being hired by the court, every single competency evaluation I've gotten so far, when I've gotten the contextual information of why this question came up, it's come up from the defense having concerns after they talked with the defendant, having concerns of defending them. And because they're being hired by a public defender, they're asking the court to do this evaluation. So even though technically I'm not being hired by the defense, so far, every single time I've done an evaluation for the court here, the framing that I've gotten for why I'm doing this has come from the defense seeking help. And so even if in theory right now, in our courts here, we said, all right, we're not going to tell you who requested the evaluation, just from practice, every time I'm going to know it's coming from the defense. And that's been another concern about mass referral ideas, is that there's some evaluation questions that just knowing the evaluation question, you know who's asking you to do this. Like only the defense would want me to look at this. Only the prosecution would want me to look at this. In Dr. Jen Perillo and I study of mass referral, we've also asked people like, can you figure out who did it? Who asked you? And most clinicians say, yeah, I know who asked me. We're still cleaning the data to see how right they are, but most people say, yeah, I know who did.
Dr. Perillo, I have real quick. It's Jessica Cave. I'm not, I'm signing on from home, so it's not up there, but, and I don't know if you have time for this, but can you say, you had mentioned going through a third party, like you looking at your postdoc fellows. Why does that not work? Why having a third party? Is it because your bias is now in it?
A couple of reasons, and that's the one that I emphasize, is that the third party then decides what information is important to you. The third party decides how to communicate that information to you. And so they're filtering out some information, but in their own way that still frames the case in a certain way. The other aspect is the idea that there are certain evaluations that that usually inherently are universally referred by one side or the other, so that in theory, even if I know that I'm being asked to do this evaluation and I get minimal reason why, just the fact that I'm being asked that question, I know what side asked me that question.
Okay, thank you.
Sure.
Thank you so much for the awesome presentation. We really appreciate it. There's a lot of accolades in the chat, and thank you.
Thanks so much. Happy to be here.